Hi guys, good morning everyone. How is the Sunday going for everyone? So today here we are, we're going to discuss the Ophthal clinical scenarios quiz that we had yesterday. And I'm sure you enjoyed, most of you said you liked the quiz, the questions. So are we up for discussion? Yes, shall we start? Good morning, hi Vinod, hello. We missed you yesterday during the discussion. Good morning. Good morning. Okay, so shall we start the discussion? So I guess the first question was image based. So this one was the image. So you can see in the left eye of this baby, there is a swelling just below the medial canthal region. Yes. And the question says this baby is 20-day-old baby and what would be the management? Yes. Now, first of all, what is the diagnosis? So the lacrimal sac is swollen here. And if you can also see very keenly, there's a little bluish tinge to it. So there is also this element of what we call dacryocystocele. Okay, it's not just dacryocystitis. Yes, so it is because of nasolacrimal duct obstruction that this has happened. So there is definitely dacryocystitis, congenital dacryocystitis because of congenital NLD obstruction, nasolacrimal duct obstruction. So I have told you in the previous discussion on lid lacrimal sclera quiz as well, I told you that the the management is completely age based. So the moment you see less than 11 months, it's going to be lacrimal sac massage. Okay, so this is 20-day-old baby, but anyway, let's look at the options. Lacrimal sac massage, dacryocystectomy, lacrimal syringing and probing, topical antibiotics. Now, some of you have gone for topical antibiotics. See, topical antibiotics by itself is not going to work. So the primary thing is lacrimal sac massage. So you do the massage followed by topical antibiotics. Yes. And topical antibiotics, again, you will not give for a longer time. As you all know, there's a lot of antibiotic resistance that's there. So it would be the lacrimal sac massage and the topical antibiotics for probably 2 weeks. And after that, stop the antibiotics and continue the lacrimal sac massage. Is that clear? And around 85 to 90% resolves with this lacrimal sac massage only. Is that clear? So, the answer is lacrimal sac massage, which is known as Krigler's massage. Okay. Okay. Again, the next one is an image-based question. But anyway, let me read out the question for you. During pre-op evaluation for cataract surgery, this clinical finding shown in the image is noted. So that means I have to take a look at the image. What is the possible intraoperative complication to be anticipated in this patient? So that is why a thorough pre-op examination is important. So when we are doing this pre-op slit lamp, we notice this clinical finding. And what is this clinical finding that you can see? You can see that dirty dandruff-like material on the pupillary ruff, on the pupillary margin. Can you see that whitish dandruff-like? And also a little bit on the anterior capsule, a little bit, one or two there. So what is the diagnosis in this case? Yes, very good, Vinod. Sorry, I didn't see your previous replies. Lavipol, very good. Dacryocystitis, very good. Vinod, yes. NLDO, very good, Vinod. It's pseudo-exfoliation syndrome. So it's pseudo-exfoliation. So in pseudo-exfoliation, what the question is very specific. It is asking you, what is the intraoperative complication that you should be anticipating? Because it's, I mean, if you don't do a pre-op examination properly, you will be in for surprises during the surgery. So you should be prepared for it. So let's see. Nuclear sclerosis. See, nuclear sclerosis occurs in pseudo-exfoliation. That is why we are doing this cataract surgery. That is not an intraoperative complication. Yes. So that is not the answer. Read the question very carefully. Intraoperative complication. I have not asked about a lens finding or what is the eye finding in this patient. No, you're already doing going to do a cataract surgery. Yeah. So the nuclear sclerosis ruled out. Floppy iris. Most of you loved floppy iris option. No, guys, floppy iris is a complication that is expected in people who are on this selective alpha 2 agonists for BPH okay, for benign prostate hyperplasia. So those people who are on selective alpha 2 agonists, what are those drugs? Type those drugs for me, because that is not ophthalmology, that is pharmacology, which you are like very good at it. So those people experience floppy iris syndrome. So that is why asking a drug history during or before cataract surgery is very, very important. And even in your third year, asking for drug history in a cataract case is very, very relevant. Not just in males, even in females, especially for incontinence, age-related incontinence, they do give this drug. Yes, so it is very important. So don't just restrict it to males. Also in females, elderly females, ask them about the use of this intake of this drug. Is that clear? Okay, so floppy iris is ruled out. Zonular weakness, yes, lens can be subluxated, or sometimes pre-op you have not noticed, but as you start doing your phaco or whatever surgery, cataract surgery, you realize, the zonule was weak. So, now it started showing all those symptoms. Nade? Is that the drug? Clonidine. But what exactly do they give? See, clonidine is okay. But I'm expecting some other answer. Something else is in my mind. Okay. All right. Good. Zonular weakness is the answer, guys. So you should be prepared for, you'll be very gentle in your cataract surgery, and also be prepared with capsular tension rings if the need be during cataract surgery. Hyphema. Now, hyphema doesn't occur in pseudo-X. Is that clear? Okay. Can we go to the next question? A 1-year-old child is diagnosed of ICRB group C retinoblastoma in the left eye. Okay, International Classification of Retinoblastoma, they already told us the diagnosis. Now, what exactly do they want to know? Which of the following is not part of the management options that would be suggested for this child? Yes, see, that is very important. No? See, once the diagnosis is done, the parents are going to ask you what are the treatment options, and you're going to tell them this are the options, and what you should not say. Okay, that is what's important, right? Because somebody must have said if there is cancer in the eye, they will take off the eye. So the parents will be very concerned. They'll ask you, okay, will you remove the eye? Will enucleation be done? No, enucleation is not necessary for group C. I told you, E for E, enucleation for group E retinoblastoma. Okay, for group E retinoblastoma. Is that clear? Okay. For group C, yes, we can do brachytherapy, localized radiation, and radioactive plaques. Enucleation, no. Transpupillary thermotherapy, yes, you can do using diode laser. Chemotherapy, yes, that is the treatment of choice for group C. So systemic chemotherapy, yes. No, it's not chemo radiation. It's not chemo radiation. It is chemotherapy. That's all. Treatment of choice is chemotherapy. It's not chemo radiation. Not at all. Not at all. Okay, be very careful on that. Chemo radiation is given for other something else. Okay, I'll not discuss that today. So retinoblastoma is chemotherapy. Good that you said that, beta. It is not radiation. Retinoblastoma, treatment of choice, one-liner would be a systemic chemotherapy. Okay. Intravenous chemotherapy. So enucleation is not advised, is not at all an option. You don't have to do that radical surgery for group C retinoblastoma. Okay, so you read that question properly. So the question actually asks, which of the following is not part of the management options that would be suggested for this child with ICRB retinoblastoma group C? Yeah. Okay, next question, quite a long question. Okay, a 35-year-old patient complains of blurry vision in both eyes on waking up in the morning, which clears up in a few hours. Okay, so he wakes up with poor vision and then it clears up in a few hours. There is no pain nor redness of eyes. Okay, what is the most likely cause? Okay, Posner-Schlossman syndrome, option A. See, Posner-Schlossman syndrome, the patient will have a lot of pain. And the blurriness is not going to go away because there's optic neuropathy because of the glaucoma. So there is an irreversible vision loss. Okay. Maybe no redness, but there's definitely pain in Posner-Schlossman syndrome. And IOP should be mentioned. There's nothing about IOP. There's nothing about the pupil, nothing else. So Posner-Schlossman syndrome is definitely ruled out. Fuchs endothelial dystrophy. See, Fuchs endothelial dystrophy, the endothelium, when it is abnormal, it will not be able to clear out the fluid that accumulates in the stroma when we are sleeping. Yeah, because when we are sleeping, the cornea goes into anaerobic glycolysis, because normally the metabolism of cornea is aerobic glycolysis. Okay. Now, when we sleep, it goes into anaerobic glycolysis. So that means what is your end product? Lactate. Lactate is hyperosmotic, so it is going to absorb fluid. So your stroma becomes edematous. Yes, all of us during sleep hours when our lids are closed. But the endothelium is good for you and me. Okay, so the water from the stroma is pumped out into the aqueous. So the cornea is clear when we wake up. So we wake up with pretty good vision. But in Fuchs endothelial dystrophy, the endothelium is stressed, it's abnormal. So what happens? The endothelium pumps are not functioning properly. So when he wakes up, that corneal edema is there. Yeah, but when he wakes, so that is why the blurry vision on waking up. No pain, no redness. And on waking up, what happens? The lids are open, back to aerobic glycolysis, no more lactic acid. So you're going to, his vision is going to clear up. Yes, so Fuchs endothelial dystrophy. Understood the concept? Okay. Okay, what about option C, cortical sclerosis? That was just a stupid option. Epithelial basement membrane dystrophy. See, epithelial basement membrane dystrophy or your Cogan's dystrophy is characterized by recurrent corneal erosion. So the patient will have pain, redness, photophobia, watering, and this decrease in vision. Okay, is that clear? Good morning, Kushwaha, Umesh. Good morning, UK. Hi, UK. Yes, take some time for me to remember your new name, UK. Yes, good. So you understand, epithelial basement membrane dystrophy is recurrent corneal erosion. So you will have a painful red eye, watering, of course, decreased vision. Yes, and photophobia. Can we move on to the next question? A patient of Sjogren's syndrome, okay, is frustrated due to the severe dryness of his eyes. Of course, yes, because that is the most common cause of keratoconjunctivitis sicca. He comes to you after having already researched well into the latest advancements in dry eye. So this chap is like most of our patients, most of the patients, they come most of the time to test your knowledge. They've already done all the research. They would have gone to 10 people, taken so many advice from doctors, from ophthalmologists. They would have taken advice from other specialists and their family members and, everyone. And Google auntie is there, and now it's not even Google auntie. Now they have AI, which gives them, a lot of updates. The latest it gives, so he doesn't even have to use his own intelligence. He can outsource it to artificial intelligence, and he comes now. Such a pain, no? Okay, but anyway, advancements in the dry eye management. Which of the following might benefit this patient? Okay, so that means you have to be updated about the latest in dry eye. This also I discussed in the previous test. Okay, let's go to this. Pilocarpine 0.125%. So pilocarpine is known to be a secretagogue. You all know, right? So what happens when you put pilocarpine? Just remember like OP poisoning. Yeah, or organophosphorus poisoning. Okay, it's a parasympathomimetic. So you have all these secretions, a lot of secretions. But pilocarpine, this 0.125% actually will do nothing because it's a dilute one. Yeah, so pilocarpine minimum is 1% or 2%, and that also we don't give for secretion of tears now. We don't give because pilocarpine has other side effects which we don't want. The patient might end up getting cataract, he might get follicular conjunctivitis, he might get iris cyst and all that. So just for dry eye, I don't want to land this patient into unnecessary complications. So pilocarpine, and that to 0.125%, I use only for the diagnosis of AD's pupil. Okay, 0.125% only for the diagnosis of AD's pupil. So not an option. Atropine 0.01%. See, atropine is something that is used to prevent the myopia progression in young children. This low dose atropine, okay, 0.01%. That also I've discussed previously. So nothing to do with dry eye. What's the next one? Ecoltramon 0.003%. Yes, Ecoltramon is the answer. Ecoltramon, I told you Pokemon. Remember the Pokemon like that, Ecoltramon. So Ecoltramon 0.003%. Okay. That is the answer. Now, what is the Seni-German? See, Seni-German 0.002% is again a latest drug. Okay, maybe we still call it latest drug, but it's been a couple of years since it's come. It is a nerve growth factor that is used in neurotrophic keratitis. Okay, they say that it helps the corneal nerves, the damaged corneal nerves to regenerate, and the corneal sensation comes back. Yeah. So for neurotrophic keratitis, Sene-German 0.00002%. Okay. Now 0.003% of Ecoltramon for dry eye. See, not that Ecoltramon is available in India. It's not available, but patient will come and ask you. Okay. So if you say okay, you don't know, you have not heard of Ecoltramon, then it's such a sorry state of affairs. Okay. So the patient will go all around saying she doesn't know anything. Okay, you tell them Ecoltramon is there, it is coming. If you want, I will import it from UK and give it to the patient. Okay, what is UK type? What, beta? Hey, I'm doing clinical scenario discussion. Look at him. He's taking teleconsultation from me now. Let me finish my discussion. A patient with Fuchs heterochromic iridocyclitis is undergoing surgery for his cataract. Of course, no. Because what are the two complications you are most likely to expect in Fuchs heterochromic iridocyclitis or your Fuchs uveitis syndrome? One is a complicated cataract, posterior subcapsular cataract, unilateral. Okay, because Fuchs is mostly unilateral. Fuchs heterochromic iridocyclitis I'm talking about. Okay, and number two is glaucoma, secondary open angle glaucoma. So these are the two complications. So this patient, as expected, he is presented with the blurring of vision for the cataract, and that's how most of the time present. So he is undergoing surgery. All right. So now surgery is going on. Which of the following events is likely to occur on making the initial side port incision? See, when you make the incision, see, there are different surgeons, different ways. So whenever you make an incision, the first incision, yeah, whether it's a main incision or a side port incision. So in this question, I've given a side port incision, because when you make an initial side port incision, what is the event that is likely to occur? Number one, vitreous upthrust. See, when you keep doing the cataract surgery, suddenly there is a vitreous upthrust. Okay, you'll feel that tension. No, that doesn't happen in Fuchs. Expulsive choroidal hemorrhage. Okay, I have seen an impending expulsive choroidal hemorrhage. I have not actually seen it, but I've heard my professors describe it. They always say, you know, the blood gushes like this and hits the ceiling. That is the expulsive choroidal hemorrhage, like a fountain of blood. Okay, so that happens when there is uncontrolled hypertension. So that is why it's very, very essential to control the hypertension before cataract surgery, during cataract surgery. Okay, so this happens in expulsive choroidal hemorrhage is a complication of uncontrolled BP. Not in Fuchs heterochromic iridocyclitis. And I think most of you loved that option. It sounded very nice, you know, and you just went for it. Option C, hyphema. Guys, you remember the Amsler's sign? Amsler's sign said in which condition? You tell me. Put it in the options. Very good, Vinod. I'm just seeing your answer. Ecoltramon. Absolutely brilliant. Where do you see Amsler's sign? And what is Amsler's sign? Where do you see Amsler's sign and what is Amsler's sign? Please put it down in the comment section. I want to see what it is. Yeah, what happened? Okay, Amsler's sign is seen in Fuchs heterochromic iridocyclitis, and it is when you do, very good, Vinod. Yes, when you do paracentesis, there's going to be hyphema. What is paracentesis? Putting a prick into the, not being a prick, putting a prick or a needle into the aqueous, into the anterior chamber. So when I do a side port incision, that's what is paracentesis, no? Yeah, the other term for it, I'm putting a incision into it. Okay, I'm making a small incision. That is paracentesis. Yes, so when you write your operative notes, you can write side port incision was made, or you can say paracentesis was done. Yeah, done. Although we do not actually actively remove the aqueous is anyway going to leak out. So hyphema is the answer. So let me read out this question for you. A patient with Fuchs heterochromic iridocyclitis is undergoing surgery for his cataract. Which of the following events is likely to occur on making the initial side port incision? I am asking, what are we expecting? Hyphema, and that is Amsler's sign. Yes, yes, very good, Vinod, absolutely brilliant. Floppy iris. Again, no floppy iris. Yeah, floppy iris only with your alpha 2 agonists. Okay. Next question. A patient suffered right eye injury with scissors 2 hours ago. 2 ghante pehle. He has come so early. Okay, to us. Right eye vision is 6 by 60. 6 by 60 means he is reading only the first line of a Snellen's chart. Okay, standing at 6 meters, he is reading only the first line, which ideally somebody. Okay, we'll discuss this some other time. Okay. Pupillary reaction is brisk. So that means my retina is not badly damaged. Optic nerve is not badly damaged. So it's okay. Good. Iris prolapse at the wound is noted. So iris is peeking out. Iris is coming out. Okay. What is iris prolapse? Iris coming out of the incision and saying hi. What is the best management strategy for this patient? Okay. So this is a case of penetrating injury. Agree? Yes, scissors, sharp object gone inside, full thickness injury. That is why the iris is coming out. Agree with me? Okay. So what is this patient at risk of? This patient, this penetrating trauma, this patient is at risk of sympathetic ophthalmia. Yes, I have that in my mind. But vision is reasonably good. 6 by 60 is able to read the first line and pupils good enough. Okay. Now, option A. Excision of prolapsed iris tissue plus primary repair of the wound. Option A. Option B. Enucleation of left eye within 2 weeks. Why would I remove the other eye? The sympathizing eye. If at all I want to enucleate, I will enucleate the injured right eye. So option B is out. Option C. Enucleation of right eye as early as possible. Option D. Enucleation of right eye at 2 weeks. See, the concept of sympathetic ophthalmia prevention and management. See, when we want to prevent sympathetic ophthalmia in the non-injured eye, in this case the left eye, I will remove the injured eye or the exciting eye as early as possible. Within 2 weeks is a golden period. But the clauses, if and only if, okay, remember, if and only if there is no visual potential in the injured eye. This eye is seeing good, no? Seeing one for the first line of the Snellen's chart. Why would you go and pluck out the seeing eye? Patient will charge you. Not charge you. Will finish off your career. Okay. So don't do that. Excision of the prolapsed iris tissue. Whatever iris or whatever uveal tissue is exposed outside. Nicely you excise it. Okay. Generously remove it. Okay. Do a nice iridectomy, whatever. Do it, and primary suturing of the wound. That is a present management. You don't have to always remove the eye, because there is always steroids to our rescue. No, you can always pump in steroids even if sympathetic ophthalmia sets in, because removing the eye is so psychologically traumatizing to the patient. Even if you put an implant, you might give good cosmesis. Okay, so we've got nice, very good ocularists who give very excellent cosmesis, even better than your normal eye. Okay, it looks so beautiful with all the sheen and all that, but still the patient will have this thing in his head. No, I don't have an eye. See, when you don't have brains, you don't have emotions, you are apathetic, you lack empathy and all that you don't know. When you don't have brains, you don't know, but when you don't have an eye, you're always reminded, I don't have an eye. So enucleation is an option only if the patient consents, and also only if there's no visual potential in the injured eye. Is that clear? Otherwise, you thoroughly excise the prolapsed uveal tissue, whatever, whether it is iris or the other parts of the uveal tract. Completely excise them, meticulously remove them, and also meticulously do a primary repair. Okay, so that is the answer. So our option in this case of this patient, presents immediately after a penetrating injury, 2 hours, okay, after a scissors has penetrated his eye, and we see there is iris prolapse. What is to be done? There is option A, that is excision of the prolapsed iris tissue along with primary repair of the wound. Is that clear to everyone? This is very, 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 very important, not just for MCQ or your NEETPG or INICET. This is important for your life. Okay. Okay. Now next one, 35-year-old female presents with complaints of reduced vision in both eyes. Oh my God. Left eye vision is 1 by 60. 1 by 60 means not even 6 meters. That first line, she has to stand at 1 meter. So she has to move closer, and only now she is able to read the first line. And left RAPD is present. relative afferent pupillary defect. Okay, so either the retina is problematic or the optic nerve is problematic. Restricted ocular motility is noted. Okay, clinical image shown. What is the first step in our management? Okay, what do you see? So this is a clinical image of the patient. Okay, 35-year-old female. What are the findings? One, left eye vision is reduced to 1/60. Left side there is RAPD and restricted ocular motility is noted. Now, what is the first step in her management? What do you think is the diagnosis? So, first of all, when you look at this patient, you know that there is proptosis in both eyes, there is lid retraction in both eyes. And in an adult, when you see this bilateral proptosis, what is your diagnosis? Yes, very good, Vinod. Yes, this is thyroid eye disease. Now, in thyroid eye disease, if a patient comes with reduced vision and RAPD, what do I suspect? This is an ophthalmic emergency because now there is compression of the optic nerve. Yes, there is compression of the optic nerve. That is why the vision is reduced. And in fact, there would be color abnormality, red-green color abnormality, and that is why there is RAPD. Yeah. So now compressive optic neuropathy, even this 1/60 will go off. Okay, so you have to manage this patient. So the question is very specific. What is the first step in her management? Option A, orbital decompression surgery, optic nerve sheath fenestration, lid recession procedure, release of fibrotic muscle. See, first thing is for compressive optic neuropathy, the first thing that you will do is release the orbital compression. So, you will do orbital decompression surgery. Yes. And definitely, by the time we do the surgery, because the patient comes today, may not be doing it today, maybe tomorrow. By that time, we will give a shot. We will start the patient on steroids so that the inflammation comes down at least a little bit. Okay, systemic steroids would be started and orbital decompression surgery. That is what will be done first. We've also seen here in this patient that there is restricted ocular motility. So that means there is an element of restricted squint. And also you saw lid retraction. So always the order is first you manage the compressive optic neuropathy. Is that clear? Next, you can manage the lid recession. Lastly, you go and manage the squint. Yes? So, first in this patient, you will do orbital decompression surgery. And orbital decompression, the order is, textbook order is you start with medial wall decompression first. You remove part of the medial wall, then the floor, lateral wall, lastly the roof because you have the brain there. So, last. Yes, so MILS, medial wall, inferior wall, lateral wall, superior wall. Okay, start with the M first. Is that clear? Okay, next question. A 15-year-old keratoconus patient develops contact lens intolerance. Which of the following options would benefit this patient? So, a typical teenager with keratoconus has been so far been managed with contact lens, now develops contact lens intolerance. That means her astigmatism has increased. Yeah. Now, which would benefit this patient? LASIK. See, first of all, the age goes against LASIK. It's not that LASIK is completely contraindicated in keratoconus. Nowadays, we combine it with C3R procedure. We do a LASIK, but at your level, generally, it's a contraindication. LASIK not done, and also at this age, because 18 years and above only LASIK. So, LASIK ruled out. Option B, cylinders and spectacles. See, if she's developed contact lens intolerance, that means she's not able to accept the toric contact lens. She has moved from regular astigmatism to irregular astigmatism. Now, irregular astigmatism, can you treat it with cylinders? That's why toric lens, contact lens intolerance. How will she be okay with cylinders and glasses? No, cylinders and glasses are not going to work for irregular astigmatism. So that is not an answer here. RGP lens, yes, rigid gas permeable lens. That is what you need to do for this patient. Give this patient who is going to benefit from this rigid gas permeable lens, because it can manage the irregular astigmatism. Is that clear? ICRS. See, ICRS, some of you have gone for it. That is your intact intracorneal ring segment. See, ICRS only after 21 years. That's a primary thing. It might help this child. This kid, okay, 15-year-old, I know they're not kids, but 21 years and more is when you can put in an ICRS. So again, the age criteria is there. Remember, so LASIK, SMILE, 18 years. ICRS, Phakic eye oval, 21 years. That is a criteria. Is that clear? Have you learned something? Yes. So in this patient, RGP lens, what is the concept? Contact lens intolerance because she has developed irregular astigmatism. Clear? Okay. Next question, a 20-year-old female presented with bilateral severe ptosis. Oh my God. Ocular motility restricted. Why too many restrictions of ocular motility? Today's questions, no? Okay. Which of the following fits the differential diagnosis? So when I see this patient, bilateral severe ptosis and movement restricted in all gazes, young female. Honors syndrome. Honors syndrome, first of all, there's always only mild ptosis. There cannot be even moderate ptosis because your molars contributes only 2 millimeter of lid elevation. So 2 millimeter ptosis only will occur. So 2 millimeter ptosis means mild ptosis. So first of all, that is gone. And why would restriction of motility occur in Honors syndrome? Poor thing, leave Honors out of it. Yeah, Honors is ptosis, meiosis, anhidrosis, that is loss of sweating, and inophthalmos and loss of ciliospinal reflex. Where is ocular motility in Honors syndrome problems? No, not at all. So Honors syndrome ruled out. Marcus Gunn jaw winking phenomenon. Anything mentioned about jaw movement, only eye movement restricted. Yes, and bilateral severe ptosis, nothing related to, yeah. So Marcus Gunn jaw winking phenomenon is ruled out. Kearns-Sayre syndrome. Yes, very good, Vinod. Yes, Kearns-Sayre syndrome is where you get CPEO, chronic progressive external ophthalmoplegia. CPEO, chronic progressive external ophthalmoplegia, because there is a bilateral severe ptosis and also it's actually not a plegia, it's a misnomer. It's not a paralysis, it's a restriction of eye movements because of fibrosis of the muscles, extraocular muscles. And also you will have a retinitis pigmentosa like picture, pigmentary retinopathy when you look into the fundus. Although that is not mentioned here, but kind of fits the diagnosis. Different, because that's what I've said, differential diagnosis. Okay. Thyroid eye disease. See, thyroid eye disease, I might have restricted eye movements, but why would I have ptosis in thyroid eye disease? I will actually have lid retraction, no? Like this one, like this lady, there would be lid retraction like this, your Dalrymple sign. Yes, lid retraction, not ptosis. So thyroid eye disease again ruled out. So Kearns-Sayre syndrome. Is that clear? So Kearns-Sayre syndrome is a combination of, you will have CPEO, chronic progressive external ophthalmoplegia. Then you will have retinitis pigmentosa like picture, pigmentary retinopathy, and also cardiac conduction defects. Okay. So in this patient that I described, a 20-year-old female, always do an ECG. Okay. Always do an ECG so that you observe if there is any abnormally prolonged PR interval, skipped beats and all that. Okay. So that is very, very important. So are we done? Oh my God, yes, we are done. Quite quickly we've done all the 10 questions. Yes. So I hope you enjoyed the quiz. So today evening, I will see you at 5 fundus walk. And 6 p.m. we have the images decoded session. We're going to decode all the images that we did in the past 1 week on Instagram. And what else? Tomorrow, no, today we don't have, do we have a quiz today? No, we don't have a quiz. And the new schedule will start on Tuesday. Shall we start tomorrow? Okay, so the new schedule of quiz, yes, I will put it out today. So the new schedule, yes, starts tomorrow. Yes, it starts tomorrow. So I will see you today evening at 5 p.m. with a fundus walk session. And please do join the test and discussion on the EyeMentor app. So the first 2 tests are free for you. You can take a look and decide if you want to join. All right. So I have given the link to join in the description. And guys, the New Year sale, I think there's just 3 or 4 more days to go. So if you want to subscribe to any of the Ophthal courses, you're most welcome to. All right. So I will see you at 5. And in the meantime, I hope you'll have a good Sunday. You're most welcome, Vinod. Bye-bye. Have a good day, guys. Ciao.